All right, so we're going to be talking a little bit about the approach to treatment when it comes to treating major depressive disorder as well as anxiety and related disorders. And I think when you talk about treatment, it's important to understand what the goal of treatment is. Like, what are we trying to accomplish? It's not reasonable for us to try to treat someone so that they are never sad and never feel anxiety. Those are feelings that when someone doesn't have MDD or doesn't have anxiety are useful, normal human experience feelings. But when it comes to having a diagnosis, it becomes pathological in the sense that it disrupts someone's functioning. So when we think about treating depression, we want to reduce their depressive symptoms. Now, elimination completely, generally not something that is reasonable. Just like if someone is being treated chronically for pain, they're occasionally still going to feel pain because that is a normal function of the human body. It just is a sensation that can be reduced and controlled to a way that someone's quality of life and functionality improves. So we, at the minimum, really want to see a 50% or greater reduction in our depression rating scales. So that could be your PHQ-9, it could be your QIDS score, etc., or achievement of a remission score. So each scale has its own remission score associated with it. And of course, at the end of the day, it's about quality of life and functioning. So we want people to have a better life at the end of the day. That is what we're here for. That is what we're trying to accomplish. Important to note is the prevention of suicide attempts and completion. So this can be a deadly disease and people can take their own lives. They can die by suicide, and really addressing that, reducing that risk is very, very important. So some of the non-pharmacological interventions that can be offered for treatment of depression. Psychotherapy. So talk therapy is appropriate for pretty much everybody. It can be beneficial. Just like with medications, though, it can take a lot of trial and error to find the therapist that works for that individual. It took me like 5 tries to find a therapist that resonated and vibed with me and that I actually felt like I could do some work with. And that can be really frustrating when you're not feeling good. It can be used as monotherapy, so it can be used alone in mild to moderate depression, which is great. We don't have to use medications in every single person who has major depressive disorder. If someone has moderate to severe, there is some data to support the combination. The risk with using combination, pretty low. There's more or less no side effects. The side effects can sometimes be mental distress from, the actions and the behavioral pieces of behavioral therapies and talk therapies. But in general, there's no significant side effects, unless it's to your wallet, because therapy is expensive. It's also time consuming. So people will often go, once a week for a period of time. Maybe they'll go twice a month after a while. And some people even go more often than that. And that can be quite expensive, especially in situations where insurance may not cover it, or there's a lot of really great therapists that are private pay because of the challenges of the insurance system. And it does require work, right? So it requires the patient to want to work the system. So the therapy client has to be desiring of that engagement, because they have to do some level of work in order for therapy to work for them. In addition to psychotherapy, there are some things that we call neuromodulation. So we have things such as bright light therapy. So bright light therapy is a really great tool for people who experience milder depression, particularly if there's a seasonal component. So, in here in Ohio, in the months of essentially October through March, it can be a bit dreary, and our brains, when we don't have as much good daylight exposure, it can cause people to feel depressed. So it's not just, going out in the sun necessarily. It actually has been studied, and there's a specific type and amount of light and frequency of exposure. So you don't go to a tanning bed. You can't go to please don't do that. But 2,500 to 10,000 lux is the unit of measurement that's usually used in these scenarios for 30 minutes in the morning. So timing does have some effect. And the timing is recommended a little bit differently if, say, someone has bipolar depression. But overall, 30 minutes a day. You have lamps, you've got visors. It has to be fairly close to the face. We also have what's called transcranial magnetic stimulation, or RTMS, which essentially maps out the brain. And then there's a machine that will basically run a magnetized force into particular parts of the brain to help stimulate it and can help improve depression. It's usually 5 days a week for like 30 sessions. It can be quite expensive, but pretty non-invasive. Additionally to that, we have ECT, which is at the bottom here, so electroconvulsive therapy, which can be incredibly beneficial for individuals who have severe depression and catatonia. So the safety of ECT is actually quite high, and the effectiveness for individuals who have severe depression is upwards of 70%, which is really, really good. It is not what you see in the movies. Ask me more about it if you want to hear more about it. Other types of therapies include exposure response therapies, which are particularly helpful for things like anxieties, eye movement desensitization and reprocessing, or EMDR, which is mostly utilized in PTSD, or post-traumatic stress disorder. It allows for the recalling of memories while distracting the brain so that someone can bring a memory to their working memory without as much distress. But it is a lot of work, and it can still cause distress. It's just, if it's the right person in the right situation, it can be much more manageable. We also have some complementary alternative treatments that might be beneficial. This is not an exhaustive list. This is probably just the most common products that I'll see people ask about or use. So St. John's wort, just don't, please. St. John's wort has some efficacy. It does have some benefit, but it is basically just a really bad Zoloft, right? In the sense of it has to be taken multiple times a day. And the more often you have to take something, the harder it is to be consistent with it. It has a lot of drug interactions, including it can reduce the efficacy of birth control pills. It has side effects. Some are quite similar to antidepressants, and it can cause photosensitivity, so increased risk of burning when you go out in the sun. So it's not a good product to use. It's just use an SSRI, right? Kava Kava is an interesting product that does have benefit. It seems to actually, especially in oral form, have benefit in treating, but there have been a multitude of cases of hepatotoxicity or liver damage from those products. And that risk versus benefit gets a little bit tricky, particularly if these are supplements. The consistent quality of those products can be challenging to determine. So, getting ISO tested products through, a third-party lab is really important. And, making sure if you are taking Kava Kava that the signs of liver failure and are monitored for that. Same kind of thing for valerian. There's not as much data, although it has been growing in popularity over the last several years or so. There have been some cases of liver function damage, so monitoring liver function periodically is recommended. Peppermint is an interesting one in that it might work, but the risk is pretty darn low. So it's one of those like low risk, low benefit type of situations where unless you're consuming excessive amounts of peppermint, it's probably okay to take peppermint oil or, chew on peppermint leaves. Probably fine. It's been studied to be safe if you're getting a good product. Other products, Sammy, I haven't seen as much of it lately. It had a moment in the early 2000s to like 2010s. It does have some efficacy. It seems to promote the production of dopamine and serotonin. It seems fairly safe to use. So it's pretty expensive, but might be an option. Generally not one that I strongly recommend, but it's certainly not as risky as some of the other products. We have L-methylfolate or Deplin. This is actually considered a medical food. So the Deplin product is a prescription, but not a prescription in the same sense, because it is essentially a supplement, but its availability is varied based on prescription. So that sounded weird to describe, but there are some people who have a mutation in the gene called the MTHFR gene, which we'll talk a little bit about later, that make it difficult for them to utilize folic acid appropriately. So there's a folic acid kind of deficiency that can happen. It can potentially benefit people who have that mutation. Again, pretty low risk. It can be quite pricey though. Omega-3 fatty acids, we study the heck out of omega-3s, and they just never really perform. Generally fairly safe if you're getting a good product. Of course, if it is a high fish content product, making sure that it is a tested product that doesn't have a lot of mercury in it. It can also increase risk for bleeding, but fairly low risk for that. And some of our antidepressants also can do that. Silexin or lavender. So lavender, like as an aromatherapy, is not super beneficial, but Silexin is a particular product that is in an oil form at a particular dose of 80 milligrams, has been studied and compared to antidepressants, seems to actually have some benefit, particularly with anxiety and a low risk of adverse effects. Most notable thing with lavender is that it might be hormone influencing in the sense of it can influence estrogen. There's not really a whole lot of cases of it. It's somewhat theoretical, but I would not recommend lavender for someone who is an adolescent masculine. I would also not recommend lavender for someone who has a history of current or significant risk for having an estrogen sensitive cancer, such as breast cancer. Just the risk isn't worth it in those types of cases, but some good data with lavender. All right, so next we're going to actually talk about prescription substances. So I will see you in just a moment, or maybe later.